So good afternoon. My name is Lucy Chaplin, Associate Director of Alumni and Parent Engagement. On behalf of Connecticut College and the Office of Advancement, I would like to welcome you and thank you all for joining us for Fall Weekend at Home. I'm joined today by Professor Monica Lopez Anuarb, Associate Professor of Economics. Professor Lopez Anuarb joined Connecticut College in 2006 as a health and inequality economics, specializing in aging, caregiving, and healthcare disparities. Professor Lopez Anuarb teaches students how to address issues of access, costs, and quality of healthcare for different populations. She also teaches about how strategic behavior among individuals, firms, and other economic agents affect those interdependent relationships. She works to diminish the inequalities of information, academic background, socioeconomic disadvantage, underrepresentation, and cultural unfamiliarity. So again, if you have any questions throughout this webinar, please enter them in the chat. But without further ado, I introduce Professor Lopez Anuarb here to discuss COVID-19 and health disparities. So welcome.
Hello, everyone. Good afternoon. Thank you for joining us during this unprecedented fall weekend, but it can still be pretty fabulous. And I am delighted to share with you some facts and suggestions that I have on the current situation of health disparities in the United States. And let's do this in a cozy way, grab a drink. Let's enjoy it. Let's assume we're in a health economics class. I've been teaching health economics since 2003. So let's see how it's going in our country. Here we go. I'm going to share my screen. All right. Okay. I think I'm also signed up as a student to make sure that you see what I see and vice versa. Okay, why don't we start from the beginning? Yeah, what are health disparities? Okay, and I want to highlight that they are actually preventable. Okay, they are differences that affect different groups differently, and they preclude them from achieving opportunities to achieve optimal health. And these differences do not necessarily have to do with individual differences with illness. They actually have to do with individuals' circumstances. The consequences of health disparities are that individuals that are hardly hit by them will have lower health outcomes and lower healthcare quality and access. And I want to take the opportunity to highlight that health disparities are multidimensional. What this means is that although they may hit certain socioeconomic groups more than others, or certain racial and ethnicities harder than others, they also do not only hit them. There are health disparities in gender, in age, in disability status, sexual orientation. So more people suffer from health disparities than we may think. And in fact, health disparities don't only come from the healthcare industry, system, or area. They are everywhere. So what you eat, where you walk, where you work, the schools you attend, the parks that you visit or do not visit, the income you make, whether you can pay your utilities or not, all contribute to health disparities. They come from non-health care areas. And suppose that you do not suffer from health disparities, that you are part of the privileged groups that have access to awesome health care, that you do not have a disability, that you live in a wonderful place with a lot of health care. Why should health disparities matter to you, to us, to all? For many reasons. One of them is that I'm hoping, as an optimist, that we like to live in a society that strives, at least if it doesn't have it, that strives for health equity, okay? Whereby people who live in it have the opportunity to reach their full potential no matter where they are coming from, no matter their circumstances, no matter their uh, wallet size or weight. So, in health economics, we like to emphasize equity over equality because equality can sometimes be problematic. If you look at this picture, you will see that there are three different people with three different heights, three different needs, given the same size crate, and yet they can't see the baseball game and they all want to see the baseball game. So why not help people who need a little bit more help with a higher size box if the goal is to watch the baseball game? Why not allow all of us to ride a bicycle and give each one of us a different bicycle so we can engage and enjoy this activity? Now, suppose that we don't care about people. It's sad, but it can be true. Okay. Why would we care about health disparities? And the reason of this is because, believe it or not, health disparities do affect us all, even from a selfish perspective. Why? Because studies show time and time again that countries with larger health disparities also have more expensive healthcare systems for all, more inefficient healthcare systems. And even if we can now afford a high quality healthcare system, if our healthcare costs are out of control, we may not be able to afford a dignified and high quality healthcare system in the future. Okay. Moreover, our population is diverse, and that's not going to change. It's only going to become more diverse. So, this is a problem that is not going to go away. So, we should care about it. I'm thinking that one thing we can do now is study health disparities before COVID, during COVID, and hopefully, if there is a world after COVID, that we also take a look at that. And I'm hoping there is going to be a world after COVID as soon as possible. If we look at a proxy of health disparities, which is how many years we think people are going to live when they are born. And we look at the life expectancy of the United States, which on average is estimated at about 79 years and ranks 45 across the list of countries. So not that great. Okay. We can see that in our own nation, we have all these colors. Okay, so what do these colors mean? Let me show you. We want to aim for the darker green shades, which represent higher life expectancy. And you can tell that there is a multicolored palette of colors here that are not necessarily green, right? I see, for example, Mississippi terrifies me, right? And the surroundings, where the life expectancy is on average 5 years smaller than the average, which is not that great to begin with. So in our own nation, life expectancy, depending on the state that we live in, on average, spans 7 years. Even magical Connecticut, I love my Connecticut, which is top 5 in life expectancy, has a 20 plus year difference within a few miles, all right, between Westport, where people on average live to almost being 90, and Northeast Hartford. So, what is going on? Well, let's check it out with this interactive um, exercise from the Robert Wood Johnson Foundation. Okay. I went ahead and typed the college's address. Okay. Our beloved Connecticut College's address. And it turns out that when I do, and I look within Connecticut and within a few miles, I realize that if we live on Mohegan Avenue, 270 to be specific, our life expectancy surpasses the nation's, and we'll see that the states and the county of New London by a lot. This is not days, we're talking about 3 to 4 years. Okay, so way above national average, way above even New London County, which is tiny, above Connecticut, which already has very high life expectancy, and almost 4.5 years or 5 above the United States. And when I shared this stat with my beloved students of the Health Economics Senior Seminar that I'm teaching this semester, one of my students said, they call me Coach. Coach, I read an article about Chicago and how on the same train ride in Chicago, there's actually a 30-year difference in life expectancy in one train ride. So this is a big deal. So what explains 30-year differences, 4-year differences, etc.? Residential segregation is one of the main reasons that explains health disparities in the United States. And residential segregation, let me read to you the definition so I get it right, because this is important, is the spatial separation of 2 or more social groups. This is important because the composition of where we live will affect the jobs that we have, the public schools that we have access to, the food that we have access to. In other words, the opportunities that we have to live our best life, our healthiest life. So the bottom line of this part of my conversation with you is that before COVID, we had serious health disparities. What about during COVID? And what happens to health disparities when we are in the midst of a pandemic? If it were only about COVID, which is already a horrible, horrible situation, but it turns out that those people who suffer from the greatest health disparities in our nation are simultaneously suffering from other pandemics, which are equally harmful. I'm talking about racism, systemic racism, right? I'm talking about financial crises. And the combination of these situations only exacerbates the COVID effect. So I'm thinking that we should participate in a poll. What do you say? All right. Let's look at Connecticut and let's look at what is happening with different groups and ethnicities in terms of their job security since February of 2020 when the pandemic started really hitting. Okay, Uh, there you go. Lucy's helping me out. So go ahead and check out what you think, who you think suffered the most from job loss in Connecticut. And then later on, we'll do poll number 2, okay, which has to do with mask wearing. But if you want to also do it now, that's fine too. How about we take a minute or so? All right, just gonna grab a sip of water. What drink are you having right now? All right. So let's focus on poll number 1, which has to do with job loss. And Lucy, you tell me when you think our dear audience is done with the poll, because I can't see.
I think probably about now we've reached, I see a couple more coming in, so that's
Oh,
great.
good.
Now, are you able to see the poll results, or would you like me to share those with you?
I can't see a thing, my dear. So go
Okay.
ahead and share the poll results.
Absolutely. So it looks like in the first question, select one. In Connecticut, 37% of blank, 22% of blank, and 18% of blank have lost their jobs or gotten laid off since February. The majority said that they think that it's Blacks, Hispanics, and then whites.
Okay, perfect. So let me share the results and then we'll talk about poll number 2. Does that sound
Right.
good?
Yes.
Awesome. Thank you. And is it okay if we close the poll, my dear?
Absolutely. And just
Thank
so
you.
you know, the Hispanics, Blacks, and Whites answer was the second most popular answer. So 9 people did select that.
Go rock on, 9 people.
Rock on. Okay, perfect. I will close the poll now.
Thank you. Indeed, in Connecticut, almost 40% of Hispanics who answered this poll provided by Data Haven in New Haven, linked to private, nonprofit organization that is very close to Yale University. Okay, they almost 40% of Hispanics lost their job or have been laid off since February, which is pretty terrifying. And then we have 22% of Blacks and 18% of whites. Translation, Hispanics were twice as hard hit by the job loss as whites were. If you do the math, right? Half of 37 is about 18.5%. Okay. Nationwide, so this is a poll that was done nationwide during let me see, I'm gonna make this larger because I'm a little blind, between July and August of this year, obviously. And this was by the Robert Wood Johnson Foundation and the Yale School of Public Health. When asked about serious, not about financial problems, about like serious financial problems, we also see differences in how the respondents answer this question, okay? 72% of Hispanics said that they were in serious financial trouble. And this poll was done mostly in cities, Chicago, California, Washington, New York. And again, half of people who said they were in trouble were whites, 36%. And of course, this has to do with the nature and the composition of the jobs in which they are. Look at Native Americans, right? Also hardly hit. And of course, so were Blacks. Now, if we decompose this a little bit more into what do we mean by serious financial problems, we see here, and in case this is too small for you, okay, that We're talking about people losing all of their savings, not being able to pay the rent or utilities. Okay, so suppose there's a moratorium for your place. What does that mean, a moratorium? It doesn't mean that your debt is forgiven. It means that in 3 months you have to pay all of those monthly rents, and you might have a roof under your head, but you might not have air conditioning or water or electricity. So that's kind of slightly pointless. Food is also an issue, and obviously medical care is a big one. And once again, you can see that the numbers are not the same, right? You can see that Latinos have serious financial problems in all cases, but their savings and rent were severely hit. Okay, now let's talk about COVID per se. I'm thinking of looking at cases and deaths in the US per state, and then at the aggregate level. Okay, we've seen that. Okay, so this is based on the Kaiser Family Foundation, a very serious organization that does some wonderful work on healthcare. And I want to explain to you the logic of this website and this page in particular. The left column allows us, it's very interactive, it's very telling, to select the groups that we're interested in. And as you can see, there are many groups that we could select. And then you can do, moreover, continue and look at this by state. So let me just move this up here, right, alphabetically. And you can see the one, all of them, a group, whatever you want. So what I did was I selected some of the states that have the highest number of cases, and Connecticut, because we love Connecticut. And there are 2 columns per group. One of them has to do with the number of cases, and the other one with the percentage of that population as a total of the population. So for example, consider California, right, which is the state that has been hit the hardest in terms of number of cases. I've lost track. I want to say maybe 800,000 cases, or very close to that anyway. And if you look at that row, we see that, for example, whites make up about 37% of the total population of California, but less than 30% of the COVID cases are coming from white people, right? So the effect is much smaller for whites than it is for Hispanics, because in California, Blacks make a small percentage of the overall population. Okay, so I just wanted to show you this so you can see the heterogeneity and diversity of differences between states, right? We can't just paint a broad brush and say that all Blacks in all states are perceiving COVID in the same way, although we will see this at the aggregate level, okay? But if you look at Hispanics, right, which actually make a larger percentage of the population than whites do, almost 40%, okay, you will see that the cases are, what is it? Let's see if I can do math on a Friday afternoon, 22 percentage points higher than the actual proportion of the population. And then you have the case of Asians, where it's the opposite, right? So the percentage of cases is lower than the percentage of the total population. Incidentally, this category of Asian really bothers me, right? So part of what we don't know, which is that if you look at the composition of Asians in the United States, there are at least 50 different types of Asians, right? But they're all grouped in one bunch. So we don't know a lot about that because our data has been poor in that regard. Now, what about Blacks in other states that have a larger percentage of the population? For example, I want to say Georgia, Mississippi. I chose Mississippi because, as you may recall from our graph, it had the lowest life expectancy to begin with before COVID. And yes, definitely hit very, very hard in terms of cases. You can see that uh, even though in Georgia, yeah, let's see, here it is. Even though in Georgia, Blacks represent 31% of the population, they're 35% of the cases. And in Mississippi, they're 46% of the cases. And even in Texas, where the population of Blacks is not as large as in Georgia and Mississippi, they make up 19% of the cases. This is in terms of cases. What about in terms of deaths? So let's focus on one specific row to see how that compares in cases of deaths. For example, California, which has small numbers, 4% cases, 5% of population. Does this translate automatically into deaths? No, right? Even in California, where the population of Blacks is small, 5%, the percentage of deaths is larger than the population. And you can see that this is a serious problem. So at the aggregate level, if you look at the United States and the death rate, okay, what is going on with deaths in general, right? Okay, you can see, because I know this is little, no need to go blind on a health economics talk, that whites make up about 60% of the population, and the death rate overall, okay, compared to a year without COVID, has been a 9% increase, okay? But in the case of Blacks, Hispanics, and even Asians, remember how we were looking at states and it looked like there wasn't necessarily a big problem in some states? Well, even in the case of Asian populations, the death rate is 35% larger this year compared to last year. And if you look at these figures and graphs, you'll see that in, I want to say April, March, I don't know, somewhere between January and July, okay, the death rate spiked very much so for Blacks, and now it's been going down, sort of, okay. But the Hispanic case is severely alarming. There seems to be a second wave, right, where the death rate was similar to Blacks, and then it started going down. And look what's happening since July, is it? Okay, it's just been creeping up, almost at at a peak as high almost as the first one, right? So even that behavior is different across groups. So in summary, right, to summarize what we've seen in those pictures, basically what's happened is that for communities of color, the deaths from all causes, including COVID, okay, has gone up by more than 30%. And even though communities of color make up 40% of the total population, they make up over 50% of the what is called excess unnecessary deaths, okay, through July. So that is also very alarming. And as a consequence, it turns out that, and this is a very interesting point that I'd like to elaborate a bit more, African Americans are 3 times more likely to know someone who has died from COVID than whites, and more than twice as likely than the overall population, which is interesting, and it makes sense that COVID has become severely politicized, right? Because if we live in a country with high levels of residential segregation, and we are only surrounded by, say, whites, like I live in a place with a very small percentage of Blacks and Hispanics. I think that when I moved to my town, the population of Hispanics doubled. So then, and we live in a place where nobody's dying from COVID, right? Then we might be like, why are people exaggerating? What's going on? Okay, is it a hoax, right? Well, African Americans can tell you that it's not a hoax by any means. And so everybody's living different experiences of COVID depending on where they live. And in fact, there was a study about residential segregation that said that if we took care of residential segregation, health disparities would go down by 2/3. So it's a big deal. So this is a loaded question. And why is it that Blacks and Hispanics and Asians are dying and suffering more from COVID? Are they wearing masks? Are they socially distancing? And notice that I'm highlighting the term they for a reason that I will explain later on. Shall we do poll number 2?
Yes, we shall. And the polls
Yeah.
are connected.
Nice.
So I'm going to relaunch in case, relaunching the poll. Okay, actually, I'm not going to do that. In fact, I think what we'll do is rely on the results that came in. So
Okay.
basically what I'm seeing is people are responding back that, I'll turn my video on if you like. There we go. So the top 3 groups in Connecticut who reported wearing a mask in August very often, the poll predicted that it is ages 65 plus at 65%, women at 69%, so that actually was the highest. And then the third highest would be ages 50 through 64. The groups that vary. The group men actually received 0%, so that was interesting. But the lowest votes were given to ages 18 through 34%, basically saying that they were only 12%. Next was Hispanics with 15%. And lastly, ages 35 through 49%.
All right, let's see what the poll says. Here we go. Okay, so check this out. The top 3 groups in Connecticut who reported wearing a mask very often in August of 2020 were Blacks, ages 65 and older, and women. And notice that the percentages are really high. We actually are lucky enough to live in a state where people, for the most part, wear masks, okay, at higher rates than other places anyway. So in those 9 categories, in fact, and you're right that men were on the lower side, even men reported that they, 79% of men, okay, so very, very nice percentage. I'm proud to live in Connecticut, reported that they were wearing masks too. But I want to focus on the fact that Blacks were number 1, okay? The other question is, are they socially distancing? Well, yes and no, right? Sometimes socially distancing is a choice and sometimes it is not. It depends on where you live and where you work, right? So it's very convenient and easy for me to socially distance. I'm here in the comfort of my home speaking to you, but not everybody has that option, right? So that's a trickier one. Okay. All right, let's talk about after COVID. Okay. Is this just going to be a bummer for the rest of the conversation and the rest of our lives? Okay. First, question number 1, will health disparities go away? Of course not. Okay, so that's important. When COVID goes away, health disparities will not go away. All right, they will continue mirroring and exacerbating what is happening, the reality that we've had for decades and maybe even centuries, right? But that doesn't mean that everything is lost, okay? We have learned stuff from as a consequence of this pandemic, and we can be better prepared. So I want to end on high note, if that's even possible. I think it is. Okay. What have we learned? Several things. Okay, there are lessons learned. Don't give up. You can't give up. Number one, we actually have more and better data, okay, on understudied groups. We had a research bias where we were always asking the same questions for the same groups and unable to know about other groups, okay? So that's really good, okay? It's really good to raise awareness because when you can measure something, you can change it. If you can't measure it, it's a lot harder to do so, okay? However, we can't just, be complacent and think that research is awesome for the sake of research, okay? We can't just stay in our ivory or our intellectual towers, okay? Reports are nice, but we need to use this information so we can effect real change and change that is systemic. What else am I suggesting we do? How about think about this as a very refreshing idea, which is how about prioritizing vulnerable communities for a change instead of having them dead last on our list? Okay. What about considering that a lot of these vulnerable communities are also our essential workers who are literally feeding us and taking care of our healthcare needs, and in return, we do nothing for them? So, what about considering them high priority groups for vaccinations and other types of support? Okay. Uh, I know that resources are expensive, but and are limited. As an economist, I'm aware of that. But it is definitely true that we can do more with the same amount of resources that we have, that it's a matter of allocation and redistribution. Okay. And in that way, we will increase the impact of the limited resources that we have. Okay. What about providing safer working conditions for these essential workers so that they are not in meat packing industries and picking up strawberries, in the middle of, say, California wildfires and COVID, et cetera, et cetera? What about funding small businesses that are already in our minority communities, who are usually ignored, unrecognized, and every day I'm thinking, say, community health centers, even in New London, okay, working hard for their communities and struggling to get funding and going through all this red tape to get assistance, okay? For example, the CARES Act, which was a stimulus package, right? $2 trillion, did some weird stuff, right? They gave, I want to say, $600, $1,200 checks, okay? Sometimes people from like the Lakers were getting checks, right? Wealthy people. Sometimes they were getting tax breaks. And then other people were not getting the checks, and small businesses were not getting the checks and going through all this red tape. So what about improving that and maybe not giving money to LeBron James, for example? Yeah, having more user-friendly mechanisms. Here's another idea. How about investing more in public health? Because it cannot be that as an economy that spends $4 trillion a year, at least in 2020 it did, that only 2% of that was allocated to public health and declining, right? So the trend is troubling. So I'm thinking that this term of herd immunity that we hear, right, in different contexts can be used in a positive way, right? What about developing herd immunity because we're stronger, as with stronger safety and social nets that make our population truly immune to some of these issues? How about not asking the same people to help us over and over again? How about we reach beyond the health silo, right? where we have non-traditional partnerships, because if you think about it, health affects us all, right? Not just the sick people, and we can get sick anytime. So what about reaching out to businesses and non-healthcare areas uh, to build a stronger communities? Think about those social determinants of health, where it's not just about whether you don't have a temperature or not, it's about whether you are living in a house with asbestos or not. So what about the housing industry? Okay, one of the consequences of this pandemic is an increase in homelessness that was already very high in certain places, and now it's going to be only higher because of eviction and moratorium time periods ending soon. What about if we stop blaming and punishing the same people that get hit over and over again, that have the most vulnerable ones, that have the least amount of resources, and stop assuming that the reason why they're sick is because of something that they did, as opposed to being victims of the circumstances in which they live, right? Because at the end of the day, this is not the last pandemic that we are going to suffer, sadly. Our world is very connected, it's very small. Their trigger effects and domino effects are only getting stronger. So I'm thinking that maybe we can be better prepared by strengthening these social and safety nets, and realizing that otherism, right? I don't know if that's a real term, is problematic, that detaching ourselves from weaker human beings is a problem, and that health disparities actually affect us all. Thank you very much.
Thank you so much. Now, we do have a few questions in the chat, and I was thinking
Yay.
that I could read them to you for response. Does that work?
Of course.
Perfect.
Happy to help.
Okay, so first question is from Andrew. Andrew asks, to what degree would switching to single payer in the US, even as just an alternative to private health insurance, fix our health equity gap, most of the gap, or just a small part of the gap?
Absolutely. Well, that's a very good question. And just to contextualize that question, right? One of the things that I didn't mention, but that I'm sure that you are aware of, is that in the midst of the pandemic, the Affordable Care Act, which was designed to reduce health disparities, and which actually did, it didn't eliminate them, all right, but it did reduce them, and which, by the way, is not a universal health care solution. So the goal was to actually ensure 2/3 of the American population. So we're not even talking about undocumented immigrants. Okay, it was just out of the 50 million people that were uninsured in 2010, 32 million Americans, right? And even the Affordable Care Act is a hybrid system, right? Is one in which the idea is that if you have private health insurance, you keep it. If you don't, then we enlarge Medicaid, right, which is the program for those low-income individuals, and we expanded Medicare to include people that were under 65 in some cases. So the single-payer system, that maybe I'm thinking maybe Canada, something like that, right? Canada does have, to a certain degree, lower health disparities. It also has health disparities, right? So it's not like a perfect solution. And I'm just thinking that I'm not sure that our country is prepared for a single payer system, and even passing the Affordable Care Act, right? We know that it's under siege, and that even if, say, Joe Biden were to win the elections, and who was part of the Affordable Care Act team, it can go away.
Mm.
The Affordable Care Act can go away because there's the Supreme Court has the Affordable Care Act after the election, and depending on the composition and on who is nominated, right, it can go away and take away the healthcare of over 20 million people. And there's a pre-existing conditions thingy-majiggy there that you might have heard on the debate. So my answer to Andrew, sorry Andrew, it's taking me so long, is that the single payer system, or a system that has a safety net, definitely diminishes health disparities, is not realistic at this point. Even say Joe Biden is not for it, okay, because the Affordable Care Act is not a single payer system. There's definitely an issue with payment here. The fact that our system is so fragmented and that it has multiple payment systems, a fee-for-service system, creates a lot of inefficiencies in terms of expenses and who is not part of the healthcare system. But it's not a complete solution, but it would definitely diminish health disparities, because even a program like the Affordable Care Act, which was not a single payer system, diminished health disparities. So I hope that I have satisfied you at least partly, Andrew.
Thank you. Next question comes from Timothy Yarborough. It's a two-part.
Go for it, Timothy.
First he was commenting on poll number 2 and said the top 2 mask-wearing groups have the poorest outcomes, which that not a question, but a statement, but yes.
Right. So I'm sorry. So does Timothy want to know who the lowest 2 groups are, or?
I think it might have been more of just a general statement, but his question is, what are your recommendations for addressing health disparities in rural areas with smaller populations of the country that have less access to healthcare resources? Yes. So how would you address health disparities in rural areas?
Oh, yes, absolutely. So so for Timothy, yes, the groups that had reported lower mask usage in Connecticut were men with 76%, okay, which is still very high, but it's 19 percentage points lower than Blacks, right? And ages 18 to 34, bad college students with 79% of the population. But hey, not just college students, right? Not just college students. Now, in terms of, on a more serious note, rural areas, right? So what is going on with rural areas? A lot of problems that are not felt. Rural areas may have lower density and hence a lower likelihood, say, of getting COVID, but they also have fewer hospitals, for example, fewer primary care healthcare workers or physicians, okay? So my recommendation here, in other words, if you do get COVID, then where do you go, right, to get even tested and cured, right? When we know in our nation, hundreds of hospitals in the rural areas have had to shut down, have had to close because they filed for bankruptcy. And this is excluding the mergers that are happening in the hospital industry. So for rural areas, my main recommendation would be to strengthen the primary care, okay, workforce or services, because this is a problem that is hitting disproportionately rural areas. And it is in primary care where you can get medical checkups and have more access to healthcare that is probably more affordable than specialty care, right? Than like getting a respiratory therapist because you can't breathe, right? So that would be my number one recommendation for that, to strengthen the primary care services.
Excellent, thank you.
You're welcome.
Next question comes from Beth.
Hi Beth.
And Beth says, these are the cases and deaths where the race/ethnicity have been collected. So I think she was talking about earlier, around 4:30 in your presentation.
Okay.
So what are the stats for the unknown? And what are the issues with not consistently collecting racial and ethnic data?
Absolutely. So let me see if I understand the first question.
Sure.
Can you repeat it again? What did Beth say again?
Absolutely.
Yeah,
So she
because
was
we
saying,
can go to the website too. So yes, what is
sure.
it?
So she
Yeah.
was saying, so these are the cases and deaths where the race and ethnicity have been collected, but what are the stats for
Yes.
the unknown?
Absolutely. Absolutely. Well, right. That's an excellent question, Beth, because even though our data is better, doesn't mean that it's, 100% accurate. And uh, more worryingly so, the data that is being reported, CDC is in trouble, right? We've heard that some of this data goes to the White House, and then the White House does some, voodoo in terms of what they report. So, in other words, translation, COVID cases that we say are in the, what is the number now? 7 million, whatever. It's way more than that, right? It's way more than that for everybody, whites, rich, everybody, right? And I work in a field where data is such a problem, right? It's such a problem, and the implications of that is that we're always underestimating these issues, right? And so while and it's a problem for two reasons, well, so many reasons. I don't want to bore you, Beth, but the reasons are because again, people are used to asking the same questions, so they don't even bother to look at the unknown cases or the small groups. But also, if you think about it historically, minorities have suffered from some research boo-boos, right? Where they were the guinea pigs of certain treatments, etc. So there's also a hesitation, yeah, from to participate in these studies because of the guinea pig syndrome, right? So I'm thinking Tuskegee, for example, right? That was a problem, right? And also sometimes the researchers have such a problem with being realistic about where the research is going to happen. So they might say, come on Tuesday at 3:00, and people maybe have to work and they have children and they can't make it to the study. Okay, so can you ask me the questions again to make sure that I'm answering them?
Absolutely. So I
Yes.
think she was just wondering, what are the issues with not consistently collecting this racial and ethnic data? Are there any implications for not being as vigilant as we could be?
Absolutely. Right. So given this context that I'm illustrating, right, with research problems and how they are, then we I think we were actually a little bit past that, that we were like underestimating the true effects of this pandemic. I think that initially we were.
Mhm.
And now I'm a little hopeful that we're learning because we're on month 9 or something. I don't know. It feels like dog years to me, right? But we are learning that the effects are larger. So I'm optimistic that even though the collection of the data is imprecise, imperfect, and problematic, that there has been a large message sent out there of the importance of collecting better data, and that minorities are really being hit. So basically, we are, with our poor data, we know that they are being hit really hard. Okay, so it's either very hard or harder, right? So I think that you as an economist and otherwise, we know that our information processing and availability is limited, right? But even with our limited information, I'm hoping that the message has been clear that minorities are being hit very hard and that health disparities do exist.
Absolutely. And looking at the clock, I think we might have time for one more question, if that's
All
okay.
right, of course.
Andrew had a second question. Thank you, Andrew.
Andrew is so engaged. I
And
love
he
it.
says, would it be feasible to finance healthcare scholarships for minorities in exchange for
Mhm.
commitments from them to work several years serving minority populations as nurses and doctors at subsidized rates for patients? Really interesting question. So I can
Brilliant.
repeat that if you'd like.
Yes,
Okay,
but I
great.
think I got it. But yes,
Okay.
please.
Would it be feasible to finance healthcare scholarships for minorities in exchange for
Mhm.
commitments from them to work several years serving minority populations as nurses and doctors at subsidized rates for patients?
I love it. This is such a wonderful question. Thank you, Andrew. Because the research shows that, well, first of all, if you look at who is going to medical school, nursing school, etc., right? Okay. Minorities are severely underrepresented, even for the percentage of the population that they make up in the country. Okay. But those minorities that do become physicians, they seem to have, in addition to a financial, um, you know, um, desire to do well, which they should in their own right, right? It's really expensive to go to medical school, for example. Okay, they seem to also have like a social desire to serve their communities. So historically, it has been shown that minorities tend to go back and serve in communities that have a large percentage of minority, representation. So that has been shown that there's this effect, right, of giving back. And one of the things that the Affordable Care Act did for minorities and otherwise was to say pardon medical debt for anybody, right, who is willing to perhaps serve in, say, a rural area, right, that we were talking about, or an area that has large shortages of medical care. So basically they said, listen, if you serve, say, 3 or 4 years here, right, okay, we will pardon your debt by half, okay, your school debt. So that was a really nice thing. And then in the case of nursing school, the percentage of minorities that are, and not just minorities, men, minorities, young people that are going to nursing school, because I want to make sure that we don't just think that primary care or any healthcare equals number of physicians. Okay, there are lots and lots of wonderful healthcare workers. I'm really excited about the nursing case and the impact of young people, minorities, and men in the nursing field, because nurses in many ways are have higher quality satisfaction rates from their patients. Okay, so patients sometimes prefer a nurse over a physician and for primary care needs. And there are also programs that are allowing them to serve in underprivileged areas, to decentralize, healthcare from hospitals to other, like, community homes. And so yes, Andrew, you've nailed it, because that has been done and it has been very, very successful. So thank you for your question.
Thank you. And
You're
yes,
welcome.
thank you to everyone who submitted a question. Thank you, Professor Lopez Anuarb, for your sunshine, your enthusiasm, and your incredible knowledge. I can't tell you how much vibrancy you brought to our fall weekend at home program. So thank you very much. And thank you to everyone who joined. And we look forward to seeing you all soon. Have a
My
great night,
pleasure.
everyone.
Happy
Thank you
weekend,
so much.
everybody.
Bye. Thank you.